Hello, everyone, and welcome to the Down Syndrome Center podcast. As always, I'm your host, Dr. Kishore Velody. And today we have yet another topic that came in from one of you, our listeners, and we're so glad to be able to answer those questions when you send them in. And at the end, of course, I'll tell you again, but please do send us your questions to Down Syndrome Center at chp.edu. But today's question is one that I'm so surprised that we have never addressed before on this podcast, and it's talking about a condition called Hirschsprung disease, which is very common, at least more common than it is in the general population in people with Down syndrome. And so I have invited a speaker today to talk with us, Dr. Kelly Austin, who, I'll let you introduce yourself, Dr. Austin, and your role at our Colorectal Center here at Children's. So why don't you start up by telling us who you are and what you do here at the hospital?
Okay, well, thank you, Dr. Velody. I appreciate the opportunity. My name is Kelly Austin. I'm a pediatric surgeon, and I've been in practice for over 20 plus years. And I head the Colorectal Center here at Children's, which is really a multidisciplinary group of mostly ped surgeons and GI physicians, but also we have some extended providers. We do have our pediatric gynecologist, a pediatric urologist, a pediatric neurosurgeon, and a pediatric PM&R person that we work closely with that addresses problems that are affiliated, problems that affect the colon mostly, or things that cause patients to have significant difficulty in normal gastrointestinal function, such as patients with Hirschsprung disease. There's also patients with chronic constipation, patients with imperforate anus or anal rectal malformations, patients with neurogenic bowel and bladder. So
Wonderful.
Thank you.
And it's such a super specialized field. Are there a lot of colorectal centers like this across the country, or is Pittsburgh pretty unique?
Well, they're becoming more appropriate and more present, I should say, in that we now are part of a multi-institutional consortium called the PCPLC, which is the Pediatric Colorectal and Pelvic Learning Consortium. And we're like one of 16 groups in the country. There are a few other centers that are dedicated to some colorectal issues, but they're not necessarily part of our group or haven't joined the consortium as yet. And still, it's relatively novel. But we're realizing how much this impacts people long term, and it's not just about doing a good operation; it's about long-term follow-up, and that we're improving the quality of life of our patients and the outcomes ultimately by having this group approach, I believe.
That's fantastic. So what this particular listener emailed us and had questions about was Hirschsprung disease, particularly as it relates to Down syndrome. But before we get to that level of specificity, why don't you just tell us, what is Hirschsprung disease? What does it even mean?
Yeah, Hirschsprung disease is an abnormality. It's a congenital abnormality where patients are born missing a certain amount of nerves in their downstream GI tract. In other words, their most downstream colon usually is absent of certain nerves that are important to its function. So for some reason in development, the nerves they usually develop in gestation. The nerves populate the GI tract from head to toe. And for some reason, they don't make it to the very, very downstream part of the GI tract in the majority of patients with Hirschsprung disease. So the disease itself could have it could be a broad spectrum of presentations, but to be honest, the 75% or so of most patients are missing just part of the rectosigmoid colon is missing the nerves. And then there's also patients who are missing longer segments of colon and nerves throughout the longer segment of colon, I should say. And there's patients who are missing nerves throughout their total colon and patients who are missing nerves throughout additional parts of their GI tract. And those are very rare.
So these nerves, I'm assuming their role then is to kind of make that colon or large intestine kind of squish to get the bowel moving. Is that right?
Exactly. Okay. So we recognize the nerves as obviously important to motility, but also they may be very important to intestinal immunity and protective things such as avoiding infection of the GI tract. So one of the things that the most common presentation is a patient without these nerves don't present often as obstructed. They don't have normal emptying of the colon, because the thought is those nerves are important to relax the colon and to help normal, what we call motility peristalsis of the colon, move along. And so what happens, although the intestine looks normal and anatomically, when for as far as function and the use of the colon, the bowel just stops to work. In other words, so the area that was missing nerves doesn't relax. And so when stool is coming down, normally it heats that part and then just backs up.
Okay. So when do you typically see this present? Is this something that a newborn baby might show up with? Because they obviously don't have those nerves right when they start, I would assume.
That's correct. The majority of our patients show up as newborns. The probably vast majority of patients are diagnosed in the first month of life, but even more so, most are presented in the first couple of days of life. And how this happens is they fail to pass meconium, or the normal stool that a baby would pass. And if this is typically in a full-term baby, should happen in the first day of life. But the vast majority of patients with Hirschsprung disease will not pass meconium in the first day of life as a full-term baby. And so, yeah, that's one of a little clue that something's wrong.
So will the babies, like when they have this, will their bellies get, big and bloated and things like that too?
Yes, thank you. Absolutely. They end up showing up, the common signs and symptoms of abnormality are that they develop abdominal distension, they may have disinterest in eating, they may be vomiting, and fail to stool to pass meconium.
So most of them, you said in baby, it will be diagnosed when they're babies. Can it be missed? Is it something that might present when they're older, school aged even? I mean, how late can you see this?
Yeah, unfortunately, there's even been adults diagnosed with Hirschsprung disease.
Wow.
It's very rare, but we do have every year, we have several patients that are diagnosed late. Most recently, I just had a patient who was 10, for example. This is not common, but they kind of, they limp along with chronic constipation symptoms. They might have some failure to thrive. They might have problems with just always having a bowel movement. They might not go for weeks at a time, or maybe, several days at a time. And their parents have just limped along with them for a while. And it takes time sometimes to make this diagnosis. But those are less common, and presumably they're the patients that have a shorter segment of aganglionosis, or a shorter segment of abnormal neurons in their GI tract.
So knowing, like, as a pediatrician, knowing how common constipation is in the general population, I mean, the diets aren't great. And also thinking about just the population of people that I take care of with Down syndrome, constipation is so common. What should be a trigger that a family or a doctor should say, hey, maybe we should be thinking about Hirschsprung that was maybe not caught in the newborn period?
Yeah, well, clearly it is a very difficult diagnosis to make. And I think you have to have an index of suspicion when a patient's just not responding to the typical treatments that a primary doctor would provide. As you noted, you see a zillion patients. Obviously, constipation is very common, but if they're not responding appropriately to that first therapy, that is garden variety therapy, that the vast majority of patients do seem to do well with. Parents often will still report. I've heard these on these later diagnosis patients that, we tried this, and we still weren't making any progress. They weren't heading in the right direction. They still had symptoms. They still, they might have been, more subtle in as far as not necessarily, they still have abdominal bloating and distension. Now, unfortunately, babies have minimal muscle, so it's pretty common for them to look poochy. But as they get older, a 2 or 3 year old shouldn't have like a kind of like a Buddha belly, kind of thing. And as they get a little bit bigger, and that's more common, obviously, with certain situations. But we haven't touched on this yet, but patients with certain problems, such as patients with Down syndrome, do have a higher association of Hirschsprung disease. Their they have something like a 50 times more incident than the general public patient. Maybe it's reported, I've seen different statistics, but up to like a 15% of patients with or Down syndrome would potentially have could have Hirschsprung disease. So it's one of those things where the incidence in the general population is 1 in 5,000, but it's more common in patients with Down syndrome to potentially have this as a source of problems with their constipation. So if for some reason they're not responding appropriately to therapy, I would be concerned about that.
All right. And I know that often when we get to that point, that's when we would refer to your clinic. And how do you confirm that diagnosis? What do you do in order to know for sure whether somebody has this?
Sure. First, we start with garden variety things like, good physical examination.
Yeah.
There could be other things wrong. I mean, patients can have abnormally located bottoms, or the anus or the opening where they stool from could not be perfect. We check them out in every way. And then typically there's a couple major tests that we get. One of them is called a contrast enema. Contrast enema is, first of all, it's not unusual for us to start with a plain x-ray, but a contrast enema is an x-ray that is a special x-ray done by radiologists where they put contrast material up the bottom into the colon and outline the colon from the inside out, so to speak, while they're observing it. So they take special images of this real time, almost like a little video. And they also take snapshots of that. And that would should look abnormal in a patient with Hirschsprung's. A patient with Hirschsprung should have something called an abnormally small rectum, which is the most downstream part of their colon compared to a larger dilated upstream colon. Because when I had said that things come down the pike, so to speak, they're kind of moving well, and then they hit this area that won't relax, and it's like a brick wall, and it backs up the upstream. So the abnormal part is the part that actually looks normal size, and the part that's responding normally is the part that's dilated because it hits this part that won't give in and it dilates up. So that helps us make the radiographically an index of suspicion, but it's not enough to prove the diagnosis of Hirschsprung's. To prove the diagnosis of Hirschsprung's, we would do a biopsy. Now, before I go on to biopsy, there's one other test that might give us a help, and that would be something called anal manometry, and it's done usually by our GI colleagues, but sometimes we can make arrangements for this. And anal manometry is in an older patient is very helpful, where it's done where they can put a small instrument with a balloon in the rectum and actually test the pressures that a patient has down there. And so patients with Hirschsprung's, I said, never relax. So they have a high tone and they have a high pressure. And that failure to relax is one of those signs that this is suspicious for Hirschsprung. So sometimes the diagnosis is made on anal manometry, which is a test, an outpatient test typically. And then lastly, we touched briefly on the diagnosis that's made, the definitive diagnosis is made on biopsy. And that's where in a young patient, we can just do this in the office. Very simple. It doesn't cause any discomfort. There's not the normal nerve fibers that you'd have on your skin and the inside of your bowels. So the patient tolerates it very, very well. And, it's called a suction rectal biopsy, and we send them off to our pathologist who then looks for those nerve cells. And if they see the absence of nerve cells, then they make the diagnosis. There's a few other stains that they do just to support that, because it's the lack of nerve cells. And just to really be 100% sure, they stain it for several other things that help them make that diagnosis. But if you were to do it on an older patient, you would probably schedule that that biopsy in the operating room under anesthesia, just so they're not uncomfortable for that, just because a bigger piece of tissue has to be done.
So let's say you do the testing, the rectal suction biopsy ends up showing that the nerve cells aren't there as expected. So you make this diagnosis of Hirschsprung disease. Then what happens? What do you do with this patient? How do you help them get better?
Sure, thank you. So if it's a very young baby, first of all, before we even go after the diagnosis, we're worried about the relief of symptoms. So
Mhm.
when an infant comes in and is really distended and super uncomfortable and isn't stooling properly, and isn't able to eat and is just in the first day or two of life, and we get an x-ray that shows massively distended bowel, lots of air throughout, and so that makes us think of downstream intestinal obstruction. That makes us think of Hirschsprung's. So in that patient, before we even do this contrast enema or any of that thing, we would do a digital exam, like I explained, a rectal exam. And a lot of times we'll get a lot of pressure where the stool will kind of push out under pressure. And that's also concerning for Hirschsprung's. And what the next thing we would do is put a little tube and decompress the bowel, and then put a little tube up the bottom, like a little soft rubber tube or silastic tube, typically, that will relax and let the air out and let help decompress the bowel. And then we would often start irrigating the intestine with some saline or salt water. And this helps us wash out the stool and wash out any bad evil humor, so to speak, or inflammatory irritation to the bowel at that point. So that's the most important thing, is the irrigations and the decompression. And if we then everything, let's say the child responds well and is looking really comfortable, then after those simple maneuvers, then we eventually make arrangements for the contrast enema and the biopsy. When we do the biopsy and get that result, and then at that point, I'm sorry to interrupt, but I mean, at that point, we would think, okay, let's make a decision. Is this baby ready for some procedure? Well, there's a couple thoughts about this. And if that contrast enema, remember I said if it might show a transition from a downstream small colon to a more upstream dilated colon. If that is a low down location, such as in the rectosigmoid area or the downstream colon, then we would be more inclined to be more successful with our decompression with these irrigations. And the thought is patients who maybe have some signs of inflammation on the biopsy as well, which are signs of enterocolitis. Those are signs of a combination of bacterial infection after being obstructed, things like that. We might want to get that taken care of before we actually do a surgical procedure. So in that situation, if the baby's responding well to our irrigations, we might send the patient home for a month or two, and then teaching the family how to do irrigations maybe twice a day, up to 3 times a day, and then bring them back and actually then do a more definitive operation where you remove the piece of intestine that doesn't have the normal nerve cells, bring the intestine that has the normal nerve cells down. Now, here's one problem. Right now, we don't know where that goes from no ganglion cells or no nerve cells to good nerve cells. So far, what we've done is just a rectal biopsy. So that means, okay, we have the diagnosis of Hirschsprung, but where does the normal nerve cells stop? Or where are their normal nerve cells? So on that x-ray, if we have that good sign of transition of skinny to big, we pretty much have an idea that it's sort of in the most common variant, which is in that rectosigmoid area. And similarly, the patient who has that downstream rectosigmoid area is also probably responding well to our irrigations. So that's probably 75 to 80% of our patients will have that presentation. And so we'll send them home on irrigations, let that enterocolitis kind of resolve, and then bring them back and do an elective surgical procedure. And at that point, there's a couple options. I know there's a lot of information. So, yeah. But at that point, we can do laparoscopically. Typically, this is what we do, is where we put a small camera in the belly button, see where we see that transition from big to small, and then take a piece of tissue there and wait for our pathologist to do what's called a frozen section, which means real time in the operating room. We're waiting for them to tell us that there are nerve cells at that piece of bowel. If we get that diagnosis back from them during that operation, that there are intestines that have normal nerve cells at that location, and that's that downstream area, then we'll proceed with a pull-through procedure, which is where you kind of mobilize and take out the bad valve downstream, bring that part down, and finish up with that. There's several different options for that as well, but those are the most common kind of approach. Now, here's the kicker is if it's more upstream, once it gets to more of the transverse colon, which is the part of the colon that goes from left to right, then we're more concerned because you're almost now a longer segment of a ganglionosis or a longer segment of abnormal bowel, and you're starting to have half the bowel be abnormal and half the bowel being of the colon, half the colon being abnormal and half the colon being normal. That child isn't maybe ready, is not a good candidate to have that upstream colon brought down to the anus, because that might cause a lot of diarrhea, a lot of loss in fluid, things like that. So the longer the level of abnormal colon, it changes our management. And we presumed that patient wouldn't have probably be tolerating our enemas very well. So when I was saying that we have a patient that we start irrigations and they're not responding well, that might mean a patient that we take emergently to the operating room and give them a temporary out, such as a ileostomy, while we let the bowel kind of recover and decompress and relieve the obstruction. Even that's a teeny bit complicated because we don't know exactly where those nerve cells are. So at that time of that procedure, we might ask our pathologist to come in and confirm that they're nerve cells where we make our ileostomy.
Interesting. So there would be like a bag on the outside of the patient then collecting the stool.
That's correct.
Got it. Okay.
So the treatment depends on where we think the normal bowel is to the downstream abnormal bowel.
Got it. And one thing I was going to ask you earlier is just for some of our providers who listen to this podcast as well, one of the things that we're taught very frequently in pediatrics is if you're suspecting Hirschsprung disease, then you should not, as a pediatrician, do a rectal exam because you might mess up the evaluation with the suction biopsy. Is that true, or is that something that is just passed on?
So it's not the evaluation with the suction biopsy. It's unfortunately the evaluation by the radiologist. But I would say that the most important thing in a patient that is concerning for Hirschsprung's is the intervention and not the diagnosis. So what I mean by that is that's not entirely true. We need the diagnosis ultimately, but the diagnosis can be made with the suction biopsy, even if a rectal exam has been done. It's just where we're asked to hold is it might distort the anatomy, make the downstream rectum look bigger than it really is by doing the rectal exam, and that makes it maybe more difficult for a radiologist to give us a possible, suspicion for Hirschsprung's diagnosis, but they can't make the diagnosis radiographically anyway. So realistically, they can just write when we have a patient that we're very, very worried for this diagnosis, we can always decompress and worry about getting that enema down the stream or contrast enema later after we're sure the patient is feeling better. So, okay. Yeah.
All right.
So I would say not to worry about doing a rectal exam, and it's okay.
Okay, perfect. Thank you. Yeah. So going back to the child who you decide to put that ileostomy bag or the bag on the outside to collect the stool, that's not forever, right? At some point, do you go back and try to reconnect it again?
Yes, absolutely. So it depends on the location. Again, one more time, we have had some patients that have small intestine that's involved with that from the small intestine down. Now, those patients, the longer the segment of abnormal intestine, now they have both small and large intestine involved with abnormality. Those patients might keep a bag, but those are extremely, extremely rare. Probably less than 1% of all patients with Hirschsprung's are going to be that patient. The vast majority of patients that get a bag urgently would be, say, a patient that has, there's maybe 25% of patients that aren't that rectosigmoid level. So if once the level becomes transverse colon or over, that starts to be a person that will probably get an ileostomy. Now, the reason why, so there's I say transverse colon or over is some patients who have total colonic, the level is the ileum. And then some patients have the transverse colon. So the decision to when to bring that down to the bottom depends on the patient. We have to have a patient that is having output out their ileostomy that is thicker, that has, not too much water. For example, we don't really want to give them a lot of trouble kind of dealing with that long segment of loss. So the colon is very, very important for us to absorb our water. And without the colon, our intestines are very important to absorb our nutrients, but we still can grow and live normal lives pretty much without the entire colon. But if you bring that down to the bottom on a very small baby, you can have a lot of bad excoriation, diaper rash, maybe water loss, things like that. So it's often better to wait. So the longer the segment, the longer we'll wait typically. So that might be an infant that has total colonic aganglionosis or abnormal nerve cells. That if the entire colon's involved, then the ileostomy might stay up to a couple years.
Wow.
Some patients will do really well and will have no problems with their growth. They're growing well. They have kind of a thick ileostomy output. Those patients might mean that their upstream small intestine has adapted to not having that colon and has been really efficient at absorbing water as well. And they might be an okay person to put together again, so to speak, to make that connection down below faster. So, there is no automatic set, but it's not unusual for if the total colon's involved, to wait about a year, but some patients can get done earlier if they're perfect. Like 6 months to 9 months maybe would be probably the youngest I've ever seen that done. And it's a little risky because, when they get a virus or a cold or whatever stuff, that's going to affect them a little bit more, and they're going to have more trouble maybe for that. So it's easier to deal with the ileostomy, believe it or not, in the first year of life than to deal with a bottom that's just all broken down and the patient's stooling constantly.
Yeah. And one thing that we've seen, so after, let's say, the surgical correction is done, and if they had an ostomy, everything potentially was all reconnected at some point months down the road. Long term, we've seen kids in our clinic who have had issues with looser stools. We've had kids in our clinic who have issues with harder stools. We've had kids who have delayed toilet training. What are some of the things that you see in your clinic for our patients?
Yeah, absolutely. And unfortunately, we'd like to think that we could make them perfect with a simple operation, but there's a lot that we don't know about with patients with Hirschsprungs, including some of their just general function of their intestine. And so there's a couple of things that are really important to talk about briefly. Is the number one important thing in patients with Hirschsprungs is something called Hirschsprung's associated enterocolitis. And that's a fancy term for infection or infection of the intestinal system. And this can happen even after a perfect operation down the road. And that's where a patient presents with abdominal distension, interested in eating, maybe explosive diarrheal stools, fever, abdominal tenderness, vomiting, etc. And those children, the thing is that it is more common to have enterocolitis in a patient who has Down syndrome. And typically the outcome is a little bit more severe. For example, patients with Down syndrome can show up with this, and we don't understand all the reasons, but it's important to recognize those symptoms and to seek medical attention quickly. Typically, it might be something as minor as needing to irrigate the rectum out a few times and to go back on some antibiotics for a short period of time. Or it could be you might want to do some bowel rest and some IV fluids, things like that. Sometimes it can be treated as an outpatient with simple oral antibiotics and good irrigations from the bottom. And sometimes you have to do you have to do a more aggressive therapy with hospitalization. So we always train our parents up about the signs and symptoms of enterocolitis because that's the most serious. Most patients, unfortunately, that if patients do succumb from Hirschsprung disease, it's typically secondary to enterocolitis and their illness. And I have to caution that unfortunately patients with Down syndrome have shown up a little more ill. In the literature, they've described them as having a higher incidence of maybe being admitted to the ICU for a short period of time to recover, but their outcomes are still can still be very good. However, if we talk about long-term outcomes is we're realizing that with all comers with Hirschsprung's, there's a higher incidence of fecal incontinence intermittently, a higher incidence of constipation, a higher incidence of even urinary accidents than the general population after this operation. Now, it's not felt from our perspective. I can tell you how we like to work this up. We always have to make sure that there's no problem with that surgical intervention. We have to make sure that there's no like stricture or maybe scar tissue that's causing a narrowing from the healing process. We have to make sure that there's no twisting of the intestine for some reason. We have to make sure. So it's very important that if a baby or a child has had this operation and that they're having symptoms of, or not doing well, having problems, that they be seen by a surgeon who can evaluate whether there's any problems with that. We have to make sure that the level that we said, where it went from normal nerves to abnormal nerves, that we brought down just the part of bowel that has the normal complement of nerves. Sometimes there's a reason why it might be still what's called a transition zone, where maybe there's some nerves, but if I were to take the whole piece of bowel completely circumferentially, then maybe it wouldn't include the whole piece. Maybe it would only include half of the bowel that have nerve cells. So we might have to go higher up and redo that procedure. So we need to roll those things out to make sure that that's right. But even if the patient has the normal nerve cells down to the bottom, has no signs of obstruction, has no twist, has everything fine from a surgical perspective, they can have these other symptoms. That we need to, and some of it could because they have a shorter intestine. And there's findings that there might be higher motility in that segment. So that gives them a rapid transit of after they eat, of poop through that area that causes them to stool quicker and have these accidents. So there's lots of things to pay attention for, too. But in general, it does seem to, there does seem to be improvement as patients age, that most people get. If they have some issues during their childhood years, they can improve once they're more adolescent. Maybe it's a combination of understanding when they, sensation, things like that improve as they age. However, you mentioned potty training, and I can say the problem with potty training is I would have to say that can be difficult with anybody who's had any issues related to their rectum. Some of it could be because they really have a problem with this diagnosis, and some of it could be because of withholding behavior, because they're afraid of what's been done in the past, or they just happen to develop that. And I think, I could think it's probably fair to say that potty training is a challenge with patients with Down syndrome anyway, correct? I would have to say.
Yes, it takes a little longer for sure. Yeah.
So one of the problems that we see with patients with Hirschsprung's is, like I said, even with a normal bringing down the good intestine down to the bottom, is that they have a higher sphincter tone typically. This is something called anal achalasia, is a fancy term for it, but they have a higher resting anal sphincter tone. And that is not uncommon with patients with Hirschsprung disease. In fact, that's the norm. So most of the time as patients get older, they understand what it takes to have a bowel movement. They know what it means to bear down and to be able to kind of, have normal bowel movements. However, it's very, very tricky in a child with potty training to, especially in a patient with Down syndrome, to truly recognize what it really takes to have a bowel movement. And so sometimes we provide therapy with something called Botox, which is an injection of a medicine that would temporarily cause the anal sphincter to relax. It's only works for about 2 to 3 months. It's not for a lifetime, but it might be enough to get someone through a rough patch for a short period, or maybe they'll need it repeated several times to get them over kind of that sphincter tone that they haven't figured out how to manage. Most of the time, this is like a lifetime thing with the sphincter tone, but usually the patient just learns how to deal with it. I mean, they learn what they need to do to have a bowel movement.
Yeah. Wow, this is fantastic. I really appreciate you spending the time today to explain this all to us and to our listeners here as well. I'm so glad that we have this Colorectal Center here at Children's that we're able to so easily refer to. We know that that's a blessing that not everybody has. So that having this information out into the community is going to be so helpful. And knowing that you guys are there for the long-term management and all that kind of stuff. Is there anything that we didn't discuss today on this podcast that you wanted to make sure that we brought up today?
Oh my goodness.
I feel like we talked about everything we could about it, but I'm sure there's way more that you think about.
Yeah, no, I really appreciate the opportunity. I mean, there are things that come up, and I think that, mostly just recognizing that most children who have this problem do well. They may have some of these issues, but they are very livable. And it is one of those things where it's a privilege to take care of. You feel like you can make their lives better. And, and I feel like as long as you understand these problems that they can have, usually you understand how to work with it. So I did bring up, I forgot to say that with our Colorectal Center, we also do what's called bowel management. And bowel management in these patients, everybody would be followed yearly at a minimum, even when they're doing well. And when they develop these issues, and we can provide, for example, patients may benefit from laxatives or something like that. But one of the things that's most important in a kid who is diagnosed early in life is you want to keep them out of problems as they're developing these, as they're growing up. So while they're doing well as an infant, maybe they do well and now they go through potty training, it becomes a rough patch. We get them through that, and then maybe they develop a period of constipation. We don't want the upstream bowel to get all stretched out, so to speak, from withholding or to just get extra distended, because they already are behind the 8 ball a little bit to have their function not be 100% perfect. And now to have another acquired thing that could cause them to have worse outcome is something that we would like to prevent. So as a Colorectal Center, I think it's really important to maintain that normal function their whole lives to prevent or just to optimize what they can get out of their function with their problem. So, that's one of the things that I think being proactive is very, very important, especially in this patient group.
Yeah. Well, thank you. And thank you to your team for your care and your commitment to working with this very important population that can be easily missed, easily neglected, even to some extent. And so glad that you exist to help us in that in our clinic as well. So to our listeners, again, to the listener who sent in this request for this topic, thank you so much. Again, for anybody who wants to have us cover a topic, please send us an email to downsyndromecenter@chp.edu, and we would be glad to find a speaker like we did today to be able to discuss that topic. If you would like to partner with us in what we do at the center, including this podcast, please do go to givetochildrens.org/Down Syndrome Center, and we would love to have you on our team in that way. But until next time, bye-bye.